Dear colleagues, before we switch back to breast cancer surgery, breast reconstruction, I would like to take the opportunity to thank the Azerbaijani colleagues for inviting me here to Baku. It's a great pleasure and honor for me to share our experience of breast reconstruction with you. It's probably the third or fourth time that I'm here in Baku, and I'm always impressed about the progression and development your country makes over the last years. I'm a plastic surgeon and a board-certified general surgeon, so we do not only the reconstructive part of the breast cancer, but also the oncosurgery on the breast. Almost 70% of our breast cancer patients in Germany are treated with breast-conserving therapy and irradiation. But still 30% of the patients have to undergo a mastectomy. Now, when we do the mastectomy and talk about reconstruction, we have to ask ourselves, what's the definition of a good breast reconstruction? Is this a good breast reconstruction? Certainly not. Is this a good breast reconstruction? Of course not, although all those women have been told they have a good breast reconstruction. But this is nothing that we can accept in the year 2015. Also, this is a Latissimus dorsi breast reconstruction. It's terrible for this woman. She would have been better off with no reconstruction and a prosthesis. I think I screwed it now. Oh, here we go. Or this patient, capsular fibrosis, no good breast reconstruction. Or even this patient who had a Latissimus dorsi flap and a scapula alata because they cut the nerve. This is not acceptable at all. What we want to achieve in a breast reconstruction is a natural-looking breast with a steep slope in the upper quadrant and the projection underneath the nipple areola complex and a kind of a teardrop-shaped breast to give a natural result to the patient. Now, nowadays, breast reconstruction is mostly done, still mostly done worldwide by expander and implants, followed by pedicled myocutaneous flaps such as the tram flap from the lower abdomen or the Latissimus dorsi flap, followed by free myocutaneous flaps such as the free tram, and the last achievements are the perforator flaps where you just transfer skin and fat to the breast to reconstruct autogenous breast tissue and no muscle impairment at all. The other question we have to ask is it possible to reconstruct the breast immediately, or do we have to do the mastectomy, do the adjuvant therapy, and then do secondly the breast reconstruction? So we delay the breast reconstruction. Delayed breast reconstruction is almost suitable in all patients, whereas immediate breast reconstruction has some presuppositions, such as the patient's request and the physician's offer, and the tumor itself. Excluded for immediate breast reconstructions are patients with tumor ulcerations, inflammatory tumors, tumors that are fixed at the pectoralis fascia. Now, there are some points to consider in immediate breast reconstruction. First of all is the oncological part. Then we have the psychological part for the patient. You know, some patients just cannot go through the cancer treatment and the reconstruction at the same time. Then the logistic part at the hospital where you're working at, is it possible to do an immediate breast reconstruction? And last but not least, the aesthetic part. From an aesthetical standpoint of view, nothing beats the immediate breast reconstruction. Now, the oncological aspects are the stage of the disease of the patient. Does the patient has to go through adjuvant therapy? The risk of local recurrency? And does the reconstruction maybe delay adjuvant therapy? This would not be justifiable. So the psychological aspects for the patients are the body image, social activities, professional life, sexual activities, and patient's motivation. The logistic aspects we have to have a histological diagnosis when we do an immediate breast reconstruction. That means that the patient has to have at least a punch biopsy of the tumor, that we know with what tumor we are dealing. You need an experienced oncologic surgeon and an experienced plastic surgeon and an adequate postoperative control. The aesthetic aspects of an immediate breast reconstruction are as follows. The submammary fold is a very important aesthetic aspect in breast reconstruction. When you can keep the fold, the symmetry almost comes by itself. You can keep, in most of the patient, you can keep the skin envelope of the breast, so you reconstruct the breast with skin texture and the same color. And where do you put the scar? Another important issue for aesthetic, and is, of course, symmetry. Symmetry is the ultimate goal of breast reconstruction, either immediately or delayed. Now, as I said, with tissue expander and implants, that's the most common kind of breast reconstruction. Here you see some expanders that we had to use for many, many years. And the industry has done a lot of effort to improve expanders as well as implants. They came up with textured implants with different sizes, different forms, different shape, different shells. So most often with whatever company you use, with the anatomical implants, you have the choice among 240 and 300 sizes of implants. So implants improved itself a lot over the years. Here's an example of an immediate periareolar skin-sparing mastectomy and an immediate reconstruction. You just take the breast out through this periareolar incision, you put the implant underneath the pectoralis major muscle, and here's an example, clinical example of a periareolar skin-sparing mastectomy and immediate breast reconstruction with an implant prior to nipple areola reconstruction. Another example of an immediate breast reconstruction with an implant through an inframammary incision. That's also an option. The weak point with the immediate reconstruction and any reconstruction with the implant is the lower pole of the breast, because you put the implant underneath the pectoralis major muscle, but here you only have the skin coverage. And the industry tried to solve that problems with the so-called ADM. ADM stays for Acellular Dermal Matrices. And these dermal matrices can be made out of bovine, pigs, or even human. And the industry did a lot of effort to sell this to a plastic surgeon to overcome this problem. It is one option, but it is an option that also has its complication. We go more into detail in the masterclass this afternoon with the ADM. The problem you always have here, you have the pocket where you put your implant in, but the lower pole of the implant, it's not covered, it's only covered by skin. So there you can use the ADM to cover the lower pole and to overcome this problem. Here's an example of this lady. She is a BRCA1 mutation carrier with breast cancer on the left side. These are the preoperative pictures, and here's her postoperative result with stratus. That's the PIC ADM, bilateral in the lower pole, vertical mastopexy, and an implant on both sides to gain symmetry. Now, the other option to overcome the problem of the lower pole with an implant reconstruction is that you just use a deepithelialized skin flap, as you can see here in this patient, but that's only possible in big ptotic breasts where you reduce the size of the breast. So it's kind of Weiss pattern reduction, as you can see here, and you use, after deepithelialization, this part of the corium to cover the lower pole of the implant. And to gain such a, this is a BRCA1 mutation carrier where we did this operation, and here is her post-operative result 2 weeks after the operation. This is another option that we very often use in big breasts where you reduce the breast and you can cover the lower pole with a de-epithelialized corium flap. And the third option I want to introduce to you is the breast reconstruction with implant and the Latissimus dorsi flap to cover the implant with autogenous tissue, as you can see here in this graphic. Here is a patient prior to the operation. Those are the preoperative pictures. Here's the postoperative pictures. We had to take out all the skin because the cancer was close to the skin. And this is her postoperative result of the nipple areola reconstruction, and reconstruction with the implant plus a Latissimus dorsi flap. And this is how the back looks. That's always a criticism that they have bad scars on the back. That's actually not true. Another patient that can see here, periareolar skin-sparing mastectomy on the right side, reconstruction with an implant and Latissimus dorsi flap. On the left side, just to gain symmetry, we did subpectoral augmentation and a periareolar mastopexy. And here you can see the scar on the right side. So there, and the nipple areolar reconstruction, of course, on the right side. Another example for Latissimus dorsi reconstruction is this patient with the breast cancer. On the left side, you can, when you look very closely, you can see the hematoma of the punch biopsy, so you know ahead of time what kind of cancer she has. And this is the pre-op, and this is her 1 year post-op result. Periareolar skin-sparing mastectomy on the left side, nipple areolar reconstruction left side with an implant. And to gain symmetry, we had to augment the right side also with an anatomically shaped implant. Another example with an immediate reconstruction with implant and Latissimus dorsi flap, pre-op, post-op, and the scars in the back. So the Latissimus dorsi flap still is a good option for reconstruction, for breast reconstruction with an implant and partially autogenous tissue. The Latissimus dorsi flap solely can only be used to reconstruct small breasts, as you can see here. In this lady in a delayed breast reconstruction, she had a small breast on the contralateral side, and this is her result after reconstruction, the breast with the Latissimus dorsi flap solely. Normally, to gain volume and to keep the volume, you need an implant. Now, there are some drawbacks with the implants and the Latissimus, of course, and that can be about 20% of the patients. You get a strange animation with muscle contraction, as you can see here. This lady had a breast reconstruction on the left side, and when she's animating the muscle, the pectoralis major muscle, you get this strange animation that you can see here on the left side, and this is really hard to treat. Or the other problem is capsular contraction. Here you see the reconstruction maybe 3 months after the reconstruction, but once the nipple areolar reconstruction is done, 1 year later she developed a capsular contracture with this double bubble phenomenon. Here the solution is just to go back into surgery, take the capsule out, and put a new implant in. So breast reconstruction with implants has some advantages, such as initial and fast operative procedure. You don't add additional scars. It's a simple operative techniques, and normally you reconstruct the breast with identical skin texture and color. But the drawbacks are, in the long run, it has a fairly high complication rate, about 30%. it gives you more or less a natural breast form and consistency as long as you reconstruct the breast with the implant solely and don't add anything like a Latissimus dorsi flap. About 10% of the reconstructed patients have a constant foreign body sensation. They just cannot accept the foreign body in the breast. Normally, the adjustment of the contralateral side is necessary in all of the patient. We don't use implant reconstruction anymore after radiation therapy because the complication rate significantly increases when you use an implant in an irradiated tissue. Now, to overcome these problems with implant reconstruction, people were looking for a solution to reconstruct the breast with autogenous tissue solely. And the preferred donor site to reconstruct the breast with autogenous tissue solely, you can see here, it's the lower abdomen and it is the buttock, where we can get some tissue to reconstruct the breast. Here you can see an example of a lady within her 60s. She underwent mastectomy on the right side, and we reconstructed the breast with what we call the DIP flap. It's a perforator flap. It's a free flap. You need the microscope for that. To just take fat and skin from the lower abdomen, no muscle at all. So you don't have any muscle impairment on the lower abdomen, and reconstruct the breast. You can see here's the scar, because here you have to reconstruct the skin envelope plus the volume. It's not only to reconstruct the volume as it is in an immediate reconstruction where you can keep the skin envelope, but here you have to get a lot of skin, which we got from the lower abdomen, and here you can see the scar in the lower abdomen. This is a result of the nipple and areola reconstruction. From the lateral view, you can see that with that way of reconstruction, you not only reconstruct a breast mount, but you also improve the whole body contour by just doing the tummy tuck. For these procedures, we need the microscope. This is microsurgery. Free DIP flap stays for a deep inferior epigastric perforator flap. This is the drawing, what we put on the belly of the patient. We rely on the deep inferior epigastric vessels that you can see here. This is just the flap from the lower abdomen turn over, and you can see the inferior epigastric vessels running into a perforator, and it's, for me, that I have done hundreds of those, it's still fascinating that this whole flap survives on those small vessels. Here's another example of a more skinny lady where we did the same procedure, reconstruct the breast with tissue from the lower abdomen as a free flap. And here's her front view, and you can see that even in not that obese patients, you get a fairly good result by reconstructing the breast solely with autogenous tissue, no foreign body. Now, the other donor side that I mentioned is the buttock. As you can see here in this drawing, we take out a piece of the buttock, not the area where people sit on, but higher. And here you see the flap. This is those are the vessels where we rely on. This is the superior gluteal vessels, and those got hooked up to the chest wall to reconstruct a breast. The S-gap stays for superior gluteal artery perforator flap, and this is our second choice. If we don't have enough tissue from the lower abdomen, then we use the buttock to reconstruct the breast. And here you see a delayed breast reconstruction. This patient underwent a mastectomy on the left side, not enough tissue on the lower abdomen, and we used the buttock to reconstruct her breast, and this is her result 1 year post-operatively after nipple areola reconstruction with a fairly good symmetry. And of course you get a scar where you take out the tissue, but you don't get a severe deformity of the buttock when you do it in the right way and on the right place. Now let me say some words about the periareolar skin-sparing mastectomy. This was a major improvement in breast surgery and in breast reconstruction because you can't keep the skin envelope. And there was always a discussion, is the periareolar mastectomy in the breast cancer patient, is it as safe as the modified radical mastectomy? And the answer is clearly yes, it is. It has the same recurrency rate and the same risk as the modified radical mastectomy. As long as the cancer is not close to the skin, you don't have any ulcerations or things like that. But when it's done properly, then it has the same safety as the modified radical mastectomy. It is necessary to keep the skin flaps very thin. Of course, you have to get all the breast tissue out, but you can do this through this periareolar incision. You even can go to the axilla to do your axillary lymph node dissection, as you can see here. You clear the axilla, and then you have a good look into the axillary region. You can preserve all the important structures, especially the intercostal branches, to keep the sensation in the inner side of the arm. Now here's an example of a patient with an immediate breast reconstruction performed through a periareolar mastectomy, pre-op, immediately post-operatively, then nipple reconstruction, and this is her final result 1 year post-operatively. And you can see the major advantage of a periareolar skin-sparing mastectomy because you can keep the skin envelope and you don't have to reconstruct the skin in a secondary stage. Another patient, she was a gene mutation carrier, very obese patient, and here is she preoperatively, and this is her result after the nipple areola reconstruction, and this is here you can see the body contour, and this is her final result 8 months post-operatively. And again, you can see that you not only did reconstruct the breast, but you also improved the whole body contour. Another patient with a bilateral reconstruction with skin and fat from the buttock with an S-gap flap. This is her result 6 months post-operatively. Still very good visible scars on the buttock, and this is her result 1 year post-op with almost faded scars. And in this series, you can see the advantage of an autogenous breast reconstruction. This lady developed breast cancer on her right side, and we reconstructed her with an S-gap flap, periareolar skin-sparing mastectomy, axillary lymph node dissection, reconstruction with an S-gap flap, and from here to there, she gained dramatically weight. But she still kept the symmetry. If you would have used an implant at that stage, she would have come out of symmetry because she gained weight. So with the autogenous tissue, whether you lose weight or you gain weight, the autogenous tissue will allow you to keep the symmetry. Sorry. Now, what are the disadvantages when we use autogenous tissue? Of course, it is an initially longer operative procedure. It's more demanding than the implant reconstruction, and you always have a scar on the donor side. Where you take the tissue, you have a scar. And in a delayed reconstruction, you reconstruct the breast with a different skin texture and color. The advantages, on the other hand, are that you have a very low complication rate and you don't have complications on a long-term follow-up, like distortion or capsular contraction or breakthrough, things that you have with implants. It's a one-time operative procedure. You always gain a natural ptosis because you have enough tissue, and you can reconstruct a natural shape. Patients don't have any foreign body sensation. And normally, or very rarely, you have to adjust the breast of the contralateral side to gain symmetry. And for us, it's the preferred procedure after radiation therapy. Now, the last thing I would want to mention is a nipple areolar reconstruction. Some people think nipple areolar reconstruction is Mickey Mouse surgery. It's not really necessary. But I can tell you, a good nipple areolar reconstruction can really improve a moderate breast reconstruction result, whereas a badly done nipple areolar reconstruction can totally destroy a good breast reconstruction. Now, what are we trying to achieve? In a breast reconstruction, we never achieve a breast form like this. Our reconstructed breasts always look more like the dome of this medieval church. It's more round. So when we do the nipple areolar reconstruction, we try to improve this round appearance of the breast. Positioning is an important issue. When you do an immediate breast reconstruction through a periareolar incision, it's very easy because you just put the nipple where it belongs to, here where you did your periareolar incision. This was a nipple sharing, very easy, very fast, no problem. But when you have a reconstructed lady like her, this is her several weeks after the surgery, and the reconstructed breast sits still higher than the contralateral side, and you would do the nipple areolar reconstruction. At that time, you would probably choose a wrong position for the nipple areolar. So we always wait 6 months until we do the nipple areolar reconstruction. That's probably totally into contrast like our American colleagues do it. But the decision for the American colleagues is mostly insurance driven because they get only one time paid for a breast reconstruction. So they have to do the whole thing at the time. What kind of reconstruction we do is, we call it the modified skate flap. It's just a technical thing. We go more into details during the masterclass this afternoon. There are several options that you can choose in nipple areolar reconstruction. The goal is to reconstruct the nipple that stands out and it keeps standing out. And this is the result after areola and nipple tattooing. And finally, the areola, there are also several options to reconstruct the areola. The most often done procedure is just tattooing, and when it's done well, it's really hard to see that it's an artificial nipple areola. Here you can see the natural nipple and areola, and this is her reconstructed nipple and areola, and you really have to look closely to see the difference. Last thing I want to mention is, with all the effort we make for a breast reconstruction, our ultimate goal in a breast cancer patient has to be the safety, the oncologically safety. We don't have to accept a compromise in the oncological procedure in favor of the aesthetic. The ultimate goal still is the safety of the patient. Thank you very much for your attention. For those of you who are interested in this topic, during the masterclass we will cover breast conserving therapy, the different options, implant reconstruction more extensively, autogenous tissue more extensively, nipple areolar reconstruction, and if we have time, we can talk also about the treatment of the gene mutation carrier. Thank you very much again.